Unsettled or crying babies. Key points. Crying is normal physiological behavior in young infants. With typical history and normal examination, no investigations are required. Parental education and close follow-up are vital to managing the unsettled or crying infant. Excessive crying is associated with higher rates of parental postnatal depression. Background. At 6-8 weeks age, a baby cries on average 2 to 3 hours per 24 hours. Colic is an outdated term used to describe excessive crying. The parents are often distressed, exhausted, and confused and often have received conflicting advice. Assessment. Clinical characteristics of normal crying. Increases in the early weeks of life and peaks around 6 to 8 weeks of age and usually improves by 3 to 4 months of age. Usually worse in late afternoon or evening but may occur at any time. May last several hours. Infant may draw up legs as if in pain, but there is no good evidence that this is due to intestinal problems. Red flags. Sudden onset of irritability and crying. Parental postnatal depression, PND, may be a factor in presentation. Excessive crying is a strong risk factor for abusive head trauma, previously known as shaken baby syndrome. Consider if crying is acute onset. Raised intracranial pressure, ICP. Injury e.g. clavicle fracture, non-accidental injury. Incarcerated inguinal hernia. Urinary tract infection. Hair tourniquet. Corneal foreign body/abrasion. Common non-pathological causes of crying. Excessive tiredness. Consider if the infant's total sleep duration per 24 hours falls more than an hour short of the average for their age. Average sleep requirements. At birth, 16 hours. At 2-3 months, 15 hours. A 6-week-old baby generally becomes tired after being awake for 1.5 hours. A 3-month-old baby generally becomes tired after being awake for 2 hours. Hunger more likely if there is poor weight gain. Differential diagnosis to consider. Non-IgE cow milk/soy protein allergy. Both can be found in human breast milk if in the mother's diet. Goat milk protein is as allergenic as cow milk protein. Suspect if there is. Significant feeding problems that persist day and night. Frequent vomiting. Diarrhea with blood or mucus. Poor weight gain. Widespread eczema. Clinical diagnosis by trialing eliminating cow/soy milk for 2 weeks. Modifying the mother's diet. Or changing to an extensively hydrolysed formula, requires pediatrician consultation. And requires resolution of symptoms or re-emergence of symptoms on rechallenge. Lactose overload/malabsorption. Consider lactose overload if infant has very frequent breast feeds and frothy, watery diarrhea with perianal excoriation. Primary lactose intolerance is extremely rare. Gastroesophageal reflux disease, GERD. No causal relationship between gastroesophageal reflux, GERD, and infant crying and irritability has been demonstrated. Blank. Proton pump inhibitors have been shown to be ineffective in reducing crying. Acute management. Investigations. If the history is typical and examination normal. No investigations are required. Management. Exclude medical cause. Parental education and reassurance. It is often helpful to explain to caregivers the potential causes of crying that have been excluded and the reasons for excluding each condition. Assess parental emotional state and mother-baby relationship. Invite the parent/s to talk about how stressful it is to care for a baby who cries persistently. Ascertain whether the parent is worried that she/he is depressed. Blank. Parental education. Engage in a partnership with the parent/. This includes acknowledging their concerns, taking time to observe the baby-parent interactions and offering follow-up. Observing the baby feed is helpful for parents who are concerned about their baby's feeding. Explain normal crying and sleep patterns. Use the normal crying curve to explain the natural history of infant crying, taken from Purple Crying. See parent information below. Use a blank blank infants cry/sleep/feeding patterns. Encourage parents to recognize signs of tiredness, frowning, clenched hands, jerking arms or legs, crying, grizzling. Assist parents to help their baby deal with discomfort and distress. Establish pattern to feeding/settling/sleep. Aim to settle the baby for daytime naps and nighttime sleep in a predictable way, e.g., quiet play, move to the bedroom. Wrap the baby, give the baby a brief cuddle, then settle in the cot while still awake. Avoid excessive stimulation, noise, light, handling. Excessive quiet should also be avoided. Most babies find a low level of background noise soothing. Darken the bedroom for daytime sleeps. Carry baby in a papoose in front of the chest. Baby massage/rocking/patting. Gentle music. Respond before baby is too worked up. Give the primary carer permission to rest once a day without the need to carry out household chores. Have somebody else care for the baby for brief periods to give the parent/s a break. Provide printed information as parents are unlikely to remember much given their state of mind at the time. Medications and other treatment options. Medication is not indicated. This includes anti-reflux medications ineffective in reducing crying compared with placebo, anticholinergic medications due to risk of serious adverse events e.g. apnoeas, seizures, colic mixtures, e.g. gripe water, no proven benefit, simethicone, e.g. Infacal trademark, no effect on crying compared with placebo. There is limited evidence to support probiotic use. Only in exclusively breastfed infants under 3 months, the probiotic, Lactobacillus reuteri, DSM-17, has been shown to be effective with excessive crying, colic, to be given as 5 drops per day orally to the infant for 21 days only. It should not be given to formula-fed infants. The probiotic has not been shown to be effective in both breastfed and formula-fed infants in Victoria, Australia. Probiotic effects are strain-specific. Lactobacillus reuteri, DSM-17938 is the only probiotic strain with some evidence of efficacy in exclusively breastfed infants with excessive crying, colic. Formula changes are usually not helpful unless there is proven cow milk allergy. Weaning from breast milk has no benefit. Spinal manipulation is not indicated and has associated. Consider consultation with local pediatric team when medical cause of crying identified or suspected. Baby clinically unwell. Admission to hospital if infant considered at risk of non-accidental injury or parental exhaustion. Consider transfer when infant requiring care beyond the comfort level of the hospital. Follow-up. Referral for early, within days, ongoing support is essential. Options include maternal and child health nurse, general practitioner, general pediatrician, hospital outpatients or private.